at the end of the day, even if nothing else is achieved through the Commission on Long-Term Care, we really welcome the opportunity for this to be a topic of public debate, for this to be something that people are very familiar with. I've been a Medicare advocate for the last 10 years, but I've been working in the Medicaid space for 22 years. And the thing that always kind of bummed me out about Medicaid is it spends most of its money on long-term services and supports, but Medicare gets all the credit for doing that. There was even a recent poll in the last couple of weeks that suggested that pretty much all seniors assume that Medicare will take care of their nursing home needs. Well, first of all, we'd love to move away from an institutional bias. Second of all, that's not something, as all of you know, it's not something that Medicare actually does. Medicare only provides nursing home services in very limited and discrete circumstances. So creating a better dialogue about what's available and when, and also encouraging folks to not just to plan, but creating options so they have something to plan from. It's all a part of what we hope for with respect to the Commission. So, you know, an easy task for you, Larry. Just please get going with that. On the demonstrations, I mean, we're very excited that the Duals office exists. We are delighted, particularly with the pieces about coordinating the two programs. The stories, for those of you who know the details, can be really crazy about, you know, Medicare covering one thing and Medicaid covering another thing, and in some instances the patient doesn't get either thing. I think from a patient perspective, the hope is to always make sure that they get the best, most appropriate option, and the coordination is what's going to make that possible. With respect to the demonstrations themselves, I guess Senator Rockefeller's office is a bit more concerned about the sort of general managed care approach, not because we don't think tremendous things have been done and can be done in that space, but the speed with which things are rolling out is a little concerning, given that so many of the plans in this space are inexperienced with a very, very complicated population. I think that there's a real sense, at least for those of us in my office, that we're concerned about making sure people do get what they need. And as we watch what's been unfolding in California as they move to sort of Medicaid managed care, we find that there really aren't a lot of options for folks, and that people actually have demonstrated themselves to be very good at navigating options when those options are available to them. But a lot of it, at least as presented to us, seems like kind of a one-size-fits-all. We've been having great conversations with colleagues in the administration and in other places about what sort of protections can be put in place, and making sure that there's adequate oversight, making sure that the metrics that are involved in evaluating these demonstrations both allow for a comparison of the various projects to one another, but also capture sort of that qualitative piece, which, while clearly trickier to measure, is ultimately, I think, in many instances, particularly for disabled folks, is, you know, the metric that matters. Are these services actually allowing them to live their lives in their community? What are those interactions like? With respect to other pieces of that, I mean, I think that the plans would probably be in a better place with some options for reinsurance and risk corridors and sort of other things that would both protect the plans and protect the patients that they're serving. And the degree to which this is being done, of course, varies quite a bit from demonstration to demonstration. Since Senator Rockefeller feels like he helped to author the provision, and he feels like he can speak very clearly to the congressional intent there. And I think that there's some concern, and this is coming from someone for whom Medicaid is a beloved program. But there is some concern that so far the demonstrations have been more focused on serving the population through the Medicaid side of the two programs rather than through Medicare. And some of that, I think, is sort of hard to get around, given the fact that Medicare has never been structured to provide these supports. But we're very much hoping that in other demonstrations as they roll out, we'll have the opportunity to see some even more novel approaches tried so that we can see how they work. I mean, and really truly use these as an opportunity to evaluate and assess options. In terms of Medicaid, I mean, we are continuing to sort of pay attention to issues for the core Medicaid population, especially related to cost sharing and making sure that the cost sharing remains nominal and doesn't create a barrier to care. And we're, very hopeful that more states will take up the expansion. That's not, of course, related directly to the long-term care piece of the puzzle, but it is something that we are watching very closely. So I'm going to end it there. I am really looking forward to having lots of good discussion.
Thank you.
Hello, everyone. Thanks for having me here today. Thanks, Anne. As Anne mentioned, my name is Sophie Kasimow. I'm the staff director of the Senate Subcommittee on Primary Health and Aging, chaired by Senator Bernie Sanders from Vermont, and we're one of 3 subcommittees under the larger Health, Education, Labor, and Pension Subcommittee. So I've been asked to say a few words today about the Older Americans Act, and as Javi, as you said, some concerns about people knowing or not knowing what Medicare and Medicaid provide. There's certainly very little information among seniors about the name recognition of the Older Americans Act, although I think it has been growing over the last 2 years, in part due to the work that I'm going to tell you about, and the work that many of you, I see some of you in this room, are doing. So, as you may know, the Older Americans Act was passed in 1965 alongside Medicare and Medicaid, and it's the major federal vehicle for the delivery of social and nutrition services for seniors in this country. The act was developed out of a real concern that there's a lack of social services and an aging network. And the act created the aging network, now sort of the aging infrastructure, the administration on aging, the 56 state units on aging, 629 area agencies on aging, 244 tribal organizations, 2 Native Hawaiian organizations, and tens of thousands of service providers. The Administration on Aging administers most Older Americans Act programs, except for CSEP, a senior jobs and community service program that's run by the Department of Labor. The law is composed of 7 titles, and it's been reauthorized numerous times over the years to respond to the needs of the country, and the older population was last reauthorized in 2006. And among many other provisions, the Act funds nutrition services, the Long-Term Care Ombudsman Program, family caregiver support, job training, and elder justice activities. The Act defines older Americans as 60 and older and targets low-income seniors in greatest economic and social need, though the program is not means tested. It was really the law was designed to support seniors to stay at home, many of whom are living in poverty, but also seniors living just above Medicaid eligibility, with a goal of preventing more costly hospital visits and long-term nursing home care. The Act expired in September of 2011, and funding has been continued through continuing resolutions. Our subcommittee was formed in May of 2011, and one of our primary goals has been to work on the Act's reauthorization. So I want to give you a quick overview of work we've done on the Hill over the last couple of years and wrap up with some what I think are very exciting recent developments as the committee prepares for a vote on the reauthorization of the Act next month. So just to give you a sense of the overall size of the program, FY 2012 funding for the Older Americans Act was $1.9 billion. That's an 18% decrease from fiscal year 2010, when stimulus funds pushed the Act to a one-time high of $2.3 billion. And this level funding over the last 10 years actually represents a 16% decrease since 2002 once you adjust for inflation. And this is, as you know, at the same time that a population over 60 has risen by over 20% over the last decade. The scope of the program, $1.9 billion seems like a lot of money, but the scope, the HHS budget is roughly $900 billion, and the June CBO report stated that we spent $250 billion on healthcare benefits for the 9 million duals in 2009, so that makes $2 billion look pretty small by comparison, but it's small but incredibly important for providing services for seniors. The largest chunk of funding under the Act are the nutrition programs, congregate and home-delivered meals, often run by Meals on Wheels. And the mention of service coordination reminds me, I could give you many examples. I was just in Vermont and visited a home-delivered congregate meals site, and they were partnering with a local hospital who was providing 10 coupons for free meals so that the senior could make sure that they were getting meals at home after they were released from the hospital to lower the hospital readmission rate. That's one of the many types of coordination where Older Americans Act services can coordinate to reduce Medicare and Medicaid costs. Title III also funds supportive services, which may include personal care, chore maintenance, assistance with toileting or bathing, transportation, and other services that help seniors stay at home. And there is very little overlap with the services provided through Medicaid, though some supportive services may be complementary or similar, such as personal care and home-delivered meals. However, unlike OAA services, Medicaid eligibility is means-tested, and in order to be eligible for certain Medicaid home and community-based services, beneficiaries also have to meet level of care criteria. So under Medicaid waivers, states can target services to certain groups, limit the number of persons covered, offer services to certain geographic areas, thus it's not necessarily statewide. And while most states offer some type of HCBS, there's really tremendous variation across the states. So OAA supportive services they're not duplicative of what Medicaid provides. And in some cases complementary, but really trying to target seniors who are near poverty before they fall into poverty and require more costly services. In 2011, so a little bit about the process, we actively sought a range of stakeholder input from many organizations, including over 40 national advocacy groups, many of whom are members of the Leadership Council of Aging Organizations, LCAO. We held 9 bipartisan listening sessions from August through October 2011. We worked with all of the Senate offices with priorities for with an interest in Act reauthorization. Over a dozen members introduced standalone legislation. We came together at the very end of the last Congress with Senators Harkin, Enzi, and Paul for a brief attempt at negotiating a bipartisan package, but we couldn't find consensus and we ran out of time, so we introduced, Senator Sanders introduced a Democratic package bill in the last Congress, S 3562, really to capture the work that had been done in the hopes that we would pick it up again in this Congress. This Congress, so we've had some changes in committee membership. The new Help Committee's ranking member is Senator Alexander, and our subcommittee ranking member is Senator Burr from North Carolina. We worked with advocates to streamline the bill from the last Congress, and we reintroduced it on May 23rd. It's S 1028 at an Older American Summit, which featured several senators and Deputy Assistant Secretary for Aging, Edwin Walker. The bill, it's much shorter than the last Congress. It captures the priorities where there was the most widespread agreement. We had a hearing, a follow-up hearing from 2011. We had a hearing last Wednesday on the role of the Act in reducing hunger and poverty. And the Help Committee has planned a markup in late July. So we've been holding staff briefings on the law, and we're now working on a manager's package. The bill uses sense of the Senate language to call for a 12% increase in funding over FY 2010 levels, reflecting a letter to appropriators that was signed by 23 senators calling for at least a 12% increase in funding, calling for increased funding, suggesting that a 12% increase would be needed because of the growing senior population. And also in light of sequestration, which really has had devastating cuts to the aging network just at the time when the boomer population is rising. And despite the fact that the Act has really been a bipartisan effort and law since its inception, and even as recently as 2006 when Republican Senator Enzi led the process, we really have a tough road ahead over the next month. We've seen in the committee, recent bills coming out of the committee, the mental health legislation, for example, that such sums authorizing language has fallen out of favor, and appropriations lines are being cut back to current authorization amounts. Current authorization amounts reflect cuts in recent years. This would really be a devastating cut for the aging network and not the direction that Senator Sanders, my boss, really believes we need to be moving in to meet the need. So I just want to touch very briefly, I know I'm almost out of time, on a couple provisions in the bill. I'd be happy to speak more about it, but tell you a few provisions that are relevant to this panel. There's a demonstration program in the Act on care coordination and service delivery. The grant program authorizes $2.9 million to test new models of care coordination and effectively deploy advanced aids. The goal would be to improve efficiency and quality of care for frail individuals while offering direct care workers the opportunity for career advancement. The Act also gives the Assistant Secretary the authority to establish a National Resource Center on Family Caregiving, authorizing $2 million a year for the center. James mentioned family caregiving. Respite care is a major portion of the Act and really extends the reach of the work that family caregivers are doing across the country by providing them with a few hours of respite care a week so that they can keep providing care that we don't count in our calculations of cost. And Senator Franken has really been a champion for the creation of a home care consumer bill of rights to address a home care consumer's right to basic safety and information about cost of services. The provisions would also work with states to extend the Ombudsman program to serve seniors living at home, something some states already do. So we're going to have a busy few weeks leading up to this vote in July, and I look forward to working with many of you as we prepare for this markup. We know that seniors want to live at home, and the Act's programs and services really do make that possible. And although there's some evidence that these programs are cost effective, we live in a data-driven era now more than ever before, and we need more of this data to show how effective these programs really are. Our challenge is making the case that providing these services, as Ito said, really is not just the right thing to do morally, but also makes financial sense as well. And I happen to think that extending the Act and these programs is almost as simple as putting the curtain inside the bathtub. We know that these programs work, they're effective, and we're going to be working hard to reauthorize this law. Happy to take any questions. Thanks so much.
Thank you. That really gives us a lot to talk about, a lot to think about, and I hope you all will prepare your questions. I'm going to take the prerogative of the moderator to kick it off. There are many interesting threads in this conversation. Obviously, the big programs, Medicare, Medicaid, and then the smaller programs, the Older Americans Act. James talked a lot about the role of managed care in helping to reshape how long-term services are delivered. And I'm wondering, I'm thinking about the guidance, James, and others who've read this, for managed long-term services and supports that was issued by CMS in May, and there are 10 essential elements in that guidance. And one of them addresses the need for a comprehensive and integrated service package. And it stipulates that institutional and non-institutional services must be included in the capitation rate. I'd be interested in your thoughts on why that was done. And then I'm generally interested, all of us I think would be, in what the federal government is generally expecting that aging services network providers and community-based organizations, what role will they be playing? Will they be subcontractors to managed care plans for purposes of providing nutrition, transportation, legal assistance, and other services that will be part of the capitation rate, or will they be separately reimbursed under the Older Americans Act, and will they have the same quality measures or different quality measures in terms of knitting this all together? And Sophie mentioned the need for cost effectiveness and getting data on that. So I know that's a lot, but if you all could reflect on that sort of bundle of questions, that would be great.
On the guidance that CMS has issued, actually we think it's quite good. Over the last couple of years, a lot of stakeholder groups have been sending in their own recommendations on what the principles of managed care applied to the senior and disability population should look like. And I think a lot of those comments were sort of rolled up and integrated into the guidance that CMS has released. And to their credit, they're also saying this guidance will be used in the approval process and also in the renewals of plans. So for plans that perhaps have not done a very good job at the get-go, I think there's an opportunity to intervene later to say these are the elements that really need to be present. So I hope this will also increase the leverage of the consumer advocates and the stakeholder communities so they can really kind of hold states' feet to the fire as state proposed plans that they can look and really check off whether those elements are present. So we're quite pleased with that. On the second question, we're doing a lot of work with our entire network of area agencies on aging, centers on independent living. We have several grants, awards that we made to try to build business skills for these organizations. Most of them have been grant-based for many, many years. And for them to assume a new role as a potential vendor for managed care plans is a whole different ball game. And a lot of the sort of services that are so important under the Older Americans Act and others aren't the type of things that managed care plans, for example, have ever sort of done actuarial projections on. And so we're sort of going into new territory. And furthermore, I think as we've talked to the really big commercial plans in particular, they're not interested in contracting with a whole bunch of one-offs. They want networks that they can contract with. So some of the work we're doing with our network is to say, you need to form your own networks and put together a business plan and a consolidated business and financial structure that you can actually enter into a contractual relationship for these services like caregiving and meals and transportation and post-hospital discharge care transitions, things like that.
Great. Anybody else have any comments on that bundle of questions? No? Okay. All right. So who out there is ready to spring forth and ask a question? Anybody? There are mics. I think there's one there and maybe one over there. Yes. Okay, great.
Yeah, hi, I'm Gail Hunt from the National Alliance for Caregiving, and I really appreciated James's comments about the family caregiver. But what I really am interested in is, I guess I don't understand exactly. It sounds to me as if pretty much all of the focus that Congress is going to be taking is going to be for Medicaid and supports to Medicaid, particularly including the aging network in, Meals on Wheels, transportation, things we've already talked about, are going to be for Medicaid. Yet, if they don't support those same kinds of services for Medicare, people are going to move into that at-risk category, at risk of institutionalization. So is there no, vision or no conception that there needs to be support to, in terms of support services for Medicare as well as Medicaid in order to keep people from reaching that at risk of institutionalization point?
So Gail, are you thinking maybe of the pre-dual population?
Yeah,
Okay,
I mean,
sorry.
this is not the duals. I think focusing on the duals is fine, but what about the vast number of people who are on Medicare who are not yet to the level of being a dual? We don't want them to get there. We don't want them to spend down and to get to that point. And we've got to support them if we don't want them to get there.
Maybe Ido and Sophie, you can talk to that.
Or Javi, I mean, I would say, one thing I would say is we don't want them either, to become, to spend down and get onto Medicaid. We being the federal government, I think the states also, I think we want to do what we can do to support individuals within the Medicare program. It's a larger issue. It's a question of what Medicare covers, but certainly from the Medicare Medicaid Coordination Office's perspective, we believe in giving as many tools as possible for sort of an expansion of the conception of what it means to serve an individual, whether it's more preventive care, which actually is already being done, a broader sort of idea of what it means to deliver telehealth services, and across the board. I think that we're, one of the agitators within our space, trying to think broadly about what it means for individuals to be served, and to the extent that there are good examples from the Medicaid world that fit within the Medicare world, certainly we want to push them forward. But again, it's a question of what is it that Medicare covers, and for better or worse, Medicare tends to cover medical stuff instead of the broader medical stuff plus LTSS that Medicaid tends to cover.
So I just want to echo some of what Ido has said. I mean, I think one of the great disappointments of seeing the Class Act fade away was that it was really a reminder that it can actually be a very small set of services that makes the difference between whether folks are sort of standing on their own and staying in their homes, or, you know, need to rely on, you know, Medicaid primarily for their supports. I mean, I think if you pull all the pieces together, you know, on either side of me, you know, people need things well beyond healthcare. You know, assistance with activities of daily living, nutrition assistance, transportation issues can sometimes be the real barriers that make all the difference as to whether people can remain living independently. Obviously, there can be some housing questions, and the reality is that we have sort of a piecemeal system. So I do think that your questions are absolutely on target. I don't know that we are in a political time right now where we're really able to step back and look at things from the 10,000-foot level and look at overall, is there a better way to structure all of the supports and not just health care? I do certainly, as someone who wants to see people succeed, but also wants to see the Medicaid program not kind of drown under its current burden, you know, would love to see Medicare take on some of these non-healthcare elements, but I don't, just from a purely practical, politically driven perspective, I don't think we're in a point to really address any of that right now.
But I would say, just to come back at this a second time, that, you know, one of the things that, you know, we've taken some criticism over the demos, but one of the abilities that the demo sort of grants these health plans is to cover stuff, as I mentioned, that's not traditional medical stuff. And it's not put in the Medicare bucket, and it's not put in the Medicaid bucket, it's put in the bucket of things that people need. It could be housing. You know, people, I was at the visiting nurse service before I came here, and people would say, well, what's the number one reason why someone ends up going from home to going to the nursing home? And my answer was, which was staggering to me even saying it, bed bugs. You know, it wasn't falls, and it wasn't housing. It was the sort of the rapid rise in bed bugs in New York City, and, you know, at least 3 years ago. So, you know, it's all this stuff, and certainly all of us up here, I think, would love to see more and more of individuals' needs being met through not only medical stuff, but the other stuff as well.
And I'll just add, I think that the point you make about pre-duals and catching people before they become a dual, whether that's in the case of the Older Americans Act, where eligibility for programs starts at age 60, we are catching people in those very critical years, and some of the data show that senior hunger, unemployment, some of the frailest vulnerable seniors are younger seniors, again when they're older, but before they're eligible for Social Security, before they turn 62, or before they're eligible for Medicare. And catching them so that when they do become eligible for Medicare, they are a little bit healthier and aren't so expensive to the system. We know that we can feed a senior for an entire year for the cost of one day in the hospital, and with an average nursing home cost of over $80,000 a year, these targeted and very modest investments really can go a long way towards lowering costs down the road.
And just to put in a plug for the ACA, I mean, I do think one of the most exciting developments is that pre-Medicare population that has really found it hardest to purchase insurance on the private market is now going to have access to care, and hopefully that will have a transforming impact on this issue.
Thank you. I think I see Josh at the microphone.
Josh Wiener, RTI International. So I have two questions. One is for Ido. So Ahaviah raised concerns about the demonstration in terms of the speed at which the demonstration was taking place, the competency of the plans in terms of their expertise on an aging and disabled population, and I guess concerns about the capacity of both CMS and the states to monitor the plans in terms of performance. So I'd be interested in your reactions to that. And then my other question would be, in part, a continuation of the discussion we were having. It's no secret that Medicaid long-term care expenditures have increased greatly over the last 20 years. And as Sophie pointed out, Administration on Aging expenditures have not. And so AOA expenditures are a smaller and smaller and smaller part of the overall long-term care system.